My name is Laura Milroy, and I'm an endodontist practicing in northern Colorado. I'd like to spend some time today discussing what is an important but often confusing aspect of endodontics, and that's the appropriate use of drugs and medications as an adjunct to endodontic therapy. I've divided the most commonly used drugs in managing this disease into three basic groups so we can discuss each individually: antibiotics, analgesics, and steroids. Let's start with antibiotics. In 1997, the ADA Council on Scientific Affairs released a statement on antibiotic use in dentistry. The basic gist of their statement is that we're not being good stewards in prescribing antibiotics, which has led to bacterial mutations and resistant strains. It's our responsibility as medical providers to provide prescriptions only when they're truly needed and to prescribe in appropriate doses so we can decrease the number of these resistant strains. In my personal experience, antibiotics are by far and away the most overprescribed medication in dentistry, and more often than not, they're just simply not necessary. Antibiotics are not a substitute for treatment. Patients will often ask me if they need to be on an antibiotic prior to initiating root canal therapy. This used to be common practice, but we now know removal of the source of infection through endodontic treatment and/or incision and drainage is more definitive and leads to faster resolution of symptoms. I know patients will often call their dentist in pain, who will then prescribe them antibiotics and/or pain medications without ever seeing them. The vast majority of infections can be effectively managed without the use of antibiotics. In order to determine if they're indicated, that patient really needs to be clinically examined. The most important decision that you're going to make is not which antibiotic to prescribe, but whether you should use one at all. As caregivers, we want to take care of our patients. It's hard for us to say no. My patients, I'm sure, are no different than yours, and they want antibiotics. They ask for them all the time. I say you have bacteria, they say antibiotic. And when I say no, there can be a perception that I don't care or I'm not providing appropriate care. It's important to take the time to explain to them why they're unnecessary and alleviate any concerns that they may have. So before we jump into when antibiotics are indicated, let's start with when you absolutely do not need them. There's no indication for antibiotics when there is a vital pulp. Remember, teeth with the diagnosis of irreversible pulpitis are not infected, but rather inflamed due to bacterial infiltration. Because there's not an infection, antibiotics are going to be useless in these cases. Many practitioners will say, well, I prescribe them because they help reduce pain. There are numerous studies that refute this thought and demonstrate antibiotics do not decrease pain. Analgesics should be utilized for pain management. So when should we be prescribing antibiotics? Other than for prophylaxis, there are really only two indications for antibiotics in endodontic treatment. The first is when there are systemic manifestations, when we see a fever, cellulitis, lymphadenopathy, or other systemic signs. We know that the infection has overwhelmed the host's immune system. Antibiotics are not needed for localized swelling unless there is an underlying medical issue. These cases can typically be managed with pulpal debridement, placement of calcium hydroxide, and incision and drainage. And lastly, patients who are medically compromised, whose immune system needs an extra boost to help control the infection, may require antibiotics. Now, I know there are many clinicians who will say, well, wait, there's a lesion below the tooth. It's full of bacteria. Why wouldn't I prescribe an antibiotic to clear up the bacteria in the lesion and help resolve symptoms? A common misconception is that a periapical lesion is generated directly by bacteria, when in reality, it's generated by the patient's immune system. This is the body's way of walling off the infection and preventing bacterial spread into apical tissues. To demonstrate the extent the bacteria are found in a lesion, I'd like to use an example from Dr. Fish, who in 1939 categorized the areas of a bone lesion into different zones. And while this model is very simplistic as to what's really going on, it demonstrates an important concept. The zone of necrosis, which is also called the zone of infection, is the only area of the lesion that contains bacteria. And as you can see from these two illustrations, that zone is limited to the root canal space and just past the apical foramen. The remainder of the lesion is made up of inflammatory components and cells from the host. Another way to visualize this is what Dr. Kronfeld has described as the mountain pass concept. He likened the bacteria in an infected root canal to an enemy army behind high mountains. The army wants to descend through a mountain pass, which in this analogy is the apical foramen, to invade the plains, which would be the periapical tissues. There's another army in the plains. This defending army represents the host's immune system. Naturally, the soldiers of the defending army are grouped around the opening of the pass to prevent the enemy army from coming through. Occasionally, some soldiers of the mountain may make it through the pass, but are usually captured and destroyed. So in this analogy, the bacteria may exit the apical foramen, but generally they don't make it too far out before they're controlled by the immune system. At a certain point, however, the army of mountain soldiers may mount a massive attack. This is clinically manifested as acute inflammation. The outcome of the battle may vary. If the bacteria win and invade the plains, this is manifest as an acute apical abscess. If the mountain army of bacteria are eliminated, either by extraction or root canal therapy, the defending army or host immune response is no longer necessary and is thus withdrawn. That's when we see resolution of the lesion. Hopefully this analogy helps clear up any questions as to why antibiotics are unnecessary when there is just a periapical lesion. So next, let's spend some time discussing which antibiotics to use. The bacterial flora of endodontic infections is mixed gram-positive and gram-negative and is predominantly anaerobic. Our first antibiotic of choice is penicillin. If you don't see a response within about 48 to 72 hours, then you can switch to clindamycin or add metronidazole to the penicillin. If the patient is allergic to penicillin, clindamycin is the drug of first choice. If no response is seen in about 48 to 72 hours, then you can switch them to azithromycin. Let's touch base on each of the antibiotics from the previous slide. I'm going to keep it clinical and to the point without getting into too much of the pharmacology. PenVK is our antibiotic of choice for endodontic infections since it is very effective in polymicrobial infections. It has a relatively narrow spectrum of activity and has low toxicity and low cost. For all antibiotics, you want to start with a loading dose of 2 times the maintenance dose to help achieve high blood levels more rapidly than if you were to start with the maintenance dose. Clindamycin is the antibiotic of choice for patients who are allergic to penicillin and is the second antibiotic to use when a patient is not responding to penicillin. Some may be hesitant to prescribe clindamycin because of the perceived increase in gastrointestinal issues, including pseudomembranous colitis. However, clindamycin does not have a higher incidence than penicillin or amoxicillin, and providers should not be afraid to prescribe it. It does have a slightly different dosage than the other antibiotics we'll look at, so it's important to note that. Amoxicillin and Augmentin, which is amoxicillin plus clavulanic acid, have a higher antibacterial effectiveness than PenVK. But because they have a higher bacterial spectrum, we typically reserve these medications for unresolved infections and patients who are immunocompromised. Augmentin tends to be more expensive. There is a generic form that has become available just in the last few years, but even the generic form still costs about $80 to $90. One thing to note is that the dosage is 3 times a day as opposed to the other antibiotics, which are taken 4 times a day. Metronidazole has the greatest amount of bacterial resistance, and because it is only effective against anaerobes, it needs to be used in conjunction with another antibiotic. It has an adverse reaction with alcohol, so patients should be advised to refrain from alcohol consumption for at least 48 hours after their last dose. Our last antibiotic is azithromycin. This is also called a Z-Pak. It's the second antibiotic of choice for patients who are allergic to penicillin. It's in the same drug family as erythromycin, so it shouldn't be given to patients who report an erythromycin allergy. It's not our first drug of choice because it is less effective against gram-negative anaerobes, which are found in endodontic infections. Patients really like it because there are less tablets to take. They come in a 3-day course or a 5-day course. I prescribe the 5-day course, which has the patient take 2 tablets the first day and then 1 tablet the remaining 4 days. The next drug group we're going to talk about is analgesics. Endodontic treatment is very good at relieving pain, but it rarely stops it immediately. Most postoperative pain is mild and usually lasts 24 to 72 hours. Those patients who come in with pain are more likely to have pain after root canal therapy. We're able to manage this pain effectively with analgesics. This is just an overview and slide for your reference of the drug combinations that I will use in patients that can take non-steroidal anti-inflammatories. We'll go over the specifics here shortly. Likewise, this is an overview of my pain management strategy in patients who cannot take non-steroidal anti-inflammatories. Again, this is just for your reference. Non-steroidal anti-inflammatories are our first drug of choice. This includes over-the-counter medications such as Advil, Motrin, ibuprofen, Aleve, and naproxen. While many patients can take NSAIDs, they are generally contraindicated in patients with ulcers, ulcerative colitis, uncontrolled hypertension, and kidney disease, patients who are taking blood thinners, and pregnant patients. We also want to check to see if they are already taking any prescription non-steroidal anti-inflammatories for any systemic conditions such as arthritis. A dosage of 200 to 400 milligrams of ibuprofen every 6 hours is adequate for mild pain. For a patient that's having moderate pain, that dosage can be increased to 600 to 800 milligrams every 6 hours. When patients are not having relief with 600 to 800 milligrams ibuprofen alone, I'll have them add 650 to 1,000 milligrams of over-the-counter acetaminophen to that. The greatest pain relief is going to be experienced when the two drugs are alternated every 3 hours. If this doesn't provide adequate relief, I will switch out the over-the-counter acetaminophen for a prescription such as acetaminophen with codeine or acetaminophen with hydrocodone. For the most severe pain, I'll prescribe acetaminophen with oxycodone, and I'll have them add that to their ibuprofen. The key is to keep them on the ibuprofen with their other pain relievers, so you're fighting inflammation and the local source of pain. Now, not all patients can take or tolerate non-steroidal anti-inflammatories. Acetaminophen is the drug of choice for patients who can't tolerate or have contraindications to non-steroidal anti-inflammatories. There are potential adverse reactions including liver damage, the rare possibility of Stevens-Johnson syndrome, and a possible association with asthma. A dosage of 650 milligrams acetaminophen, which is 2 regular strength Tylenol, or 1,000 milligrams, which is 2 extra strength Tylenol, every 6 hours is adequate for mild pain. For a patient that's having moderate pain, I'll write them a prescription for acetaminophen plus codeine, which is Tylenol number 3. This chart is a little bit older, so it does need to be modified in regards to prescriptions written with acetaminophen in them. In 2011, the FDA announced that in an effort to decrease liver toxicity associated with overdoses of acetaminophen, it would require manufacturers of prescriptions to decrease their dosage of acetaminophen to 325 milligrams. So as of 2014, 500 milligram doses are no longer available. For moderate to severe pain, acetaminophen with hydrocodone or oxycodone can be prescribed. This is a great overview of the drugs we've discussed. The one drug we haven't mentioned on here is tramadol. Tramadol is a narcotic-like analgesic that can be used for patients who cannot tolerate other opioids. It can be given alone or in combination with acetaminophen. So the last drug class we'll discuss is steroids. Of all the drugs we've talked about today, this is probably the most unfamiliar to dentists and the drug you're probably least comfortable with prescribing, but it's a great tool to have in your armamentarium. Steroids can be given intramuscularly as an intracanal medicament or by intraoral injection, but we're going to discuss the most common way to give them, and that is orally. Steroids are more effective at reducing inflammation, which is the source of pain than non-steroidal anti-inflammatories. Steroids act higher up in the inflammatory chain and affect more inflammatory components than compared to non-steroidal anti-inflammatories. When I tell a patient that I want to prescribe them a steroid, I hear a whole host of reasons why they don't want to take one. Usually this stems from a previous experience where they had negative systemic effects. These are typically the same reasons I hear from dentists as to why they may be hesitant to prescribe a steroid. Steroids do have an effect on many organ systems, but they have to reach greater than physiologic doses over a long-term period, which is usually more than 2 weeks. The steroids that we are going to be prescribing are a much shorter course, and as such, we don't have to worry as much about these systemic side effects. If you have never prescribed a steroid before, these may be some of the questions that you might be asking yourself. Let's go through each of these so you're comfortable prescribing them. When should you prescribe steroids? This is a very subjective question. There are relatively few studies and articles that address this topic in endodontics, so I can only give you my opinion, which is based off what research is available. I will prescribe a steroid when traditional pain management strategies are not working. I'll have the patient stop ibuprofen and switch to the steroid, but continue taking the acetaminophen and/or the narcotic. The combination of steroids and nonsteroidal anti-inflammatories can cause adverse gastrointestinal reactions, so it's best to stop the nonsteroidal anti-inflammatory drug. I'll also prescribe steroids if a patient is having persistent pain which lasts longer than normal. For example, if a patient comes in a week after treatment is completed and says they're still having tenderness with the tooth and they're taking ibuprofen every day, I'll go ahead and prescribe a steroid. There are arguments as to whether steroids should be given when the pulp is necrotic or vital, but there is sufficient evidence to suggest that they are beneficial in both cases, as inflammation is the underlying cause of both. There are relatively few true contraindications for corticosteroids. A systemic fungal infection or known hypersensitivity are absolute contraindications. There are a number of medical conditions in which they should be used with caution. If you have any question as to whether a patient can take them or not, you should contact their physician. Psychologic disturbances may occur and can range from mild to pronounced. These are reversible when the drug is discontinued. There are also relatively few drug interactions, and those that do interact decrease the level of steroid available. There is always the concern, because we're decreasing the inflammatory response, that we're also decreasing the immune system's ability to fight infections. Again, because it's such a short dosage, for most healthy patients, antibiotics are unnecessary. If you have any question in medically complex patients, consult with their physician. So what steroids should you prescribe? Cortisol is the corticosteroid that we naturally produce, and everything is compared to it. Methylprednisolone is one available steroid. It's 5 times as potent as cortisol and has twice the plasma half-life. Dexamethasone is a second steroid available to prescribe. It is 5 times more potent than methylprednisolone and 25 times more potent than cortisol. There are relatively few guidelines on specific dosages of these steroids. In his review of steroid use in endodontics, Dr. Marshall extrapolated some recommended doses based on a compilation of studies. He recommended 48 milligrams of methylprednisolone per day for 3 days. However, the most convenient way to prescribe methylprednisolone is in a Medrol dose pack. It is a lower but longer dosage than recommended by Marshall. It comes as a 6-day course. The first day, 6 tablets are taken. Each day, the dose is decreased by 1 tablet until it's gone. Marshall's recommendation for dexamethasone is 10 to 12 milligrams per day for 3 days. I typically give about 8 milligrams a day, so a slightly lower dosage. They come in 4 milligram tablets, so if you wanted to increase to 12 milligrams a day, you could write the script for 3 times a day as opposed to twice a day. So these are some of the guidelines that I follow when prescribing steroids, antibiotics, and analgesics. I hope you have found this helpful. Thank you again for joining our chair time session.